I would like to demonstrate, this is vertebral augmentation section. I'd like to demonstrate to you the three primary ways that we approach a vertebral body. So these will be useful to you. I'm not good enough to do every augmentation or every single osseous approach using one method, but you will need to use some of these other methods. It's always good to have a baseline. While we do this, we have our tumor ablation. So this is the Osteocool system that will be doing the tumor ablation. And this is a vertebral body that has probes placed into it. And this will ablate in kind of an elliptical fashion most of the surface area of the tumor that will be afflicting this vertebral body. And this is demonstrated by chicken breast. So we will cook and eat this later after the Osteocool has a chance to ablate the tumor in the center. And the chicken breast is very good demonstration of this as it changes color and texture. So back to our cadaver, let's see what we have. So we will use a typical approach. And we have on a transparticular approach, arc a little bit toward me, arc toward me a little bit. I want to make sure that the spinous process is lined up perfect and it's right directly AP. So from the outer portion of the pedicle, it's centimeter up, 2 centimeters out, and this is the typical start point for the transparticular approach. So on one side, it is 10 o'clock, and the other side is 2 o'clock. All right, so 10 o'clock on this side, 2 o'clock on the other, and you come down and you hit os, and I'm using a single bevel needle. As you can see, that's a directional. You come down, and the only real rule of thumb that you have to abide by is never violate the medial wall of the pedicle before you are in the posterior portion of the vertebral body. So if you need extra room, I want you to focus on the medial wall and the distal tip of that needle. And then when I turn it around to the flat part, it gives you a few extra millimeters. So if you need a few extra millimeters, let's go lateral. Then you can always turn the point of the bevel, and keeping in mind using a single bevel needle that steers away from the face of the bevel, steers toward the point, away from the face, and we'll check it out and see where we are. And we are in the posterior portion of the vertebral body. Can you drop it down just a hair? No, I mean raise it up. The eye down, yes. Better. So we will advance into the vertebral body from this point. And we'll come back around. Once we get to within 3 to 5 millimeters, we'll come back around and check our AP position. And we want to be in the single half of the vertebral body. We want to be between the pedicle and the spinous process. And that's where we are. And we'll put the same component on the other side, and that's how we do a transparticular approach. Perpendicular approach is a little bit different than that. It's on a line that goes from ipsilateral superior to contralateral inferior vertebral corner. That's for the drill. Drill, yep, perfect. And so in this line, we'll go out here, 1 vertebral body width. So that's about a vertebral body width from the ipsilateral superior corner. And if you look on our cadaver here, this is just the same as a transparticular approach, just farther out. So perpendicular approach, the start point will be just a little bit farther out. And we'll come down until we hit os. So one of the things I like to do here is just do a check. So right here, when we first hit bone, you can arc 20 degrees ipsilateral to the site of the vertebral body that you're going in to show where the needle tip position is. And right in here, I can feel bone, and we are just in front of the pedicle. So you can demonstrate that we're right anterior to the pedicle and that we are at or above the equator. And that's of the center of the pedicle. And so this is the perfect position. And we'll come back around to AP. And we're just almost crossing, just have crossed the medial wall, and I can feel the posterior portion of the vertebral body. So let's take a lateral view. And remember, you always want to check and make sure you're in the posterior portion of the vertebral body. And from a wider swath, a wider start, our target here with the perpendicular approach should be the center portion of the vertebral body. So we're well into the vertebral body, and one of the ways that you can get to the center is I'm just going to pull it back a little bit toward the posterior portion and use the bevel of the needle to my advantage to just put it into the center portion of the vertebral body. So we are right about the center there, maybe a tad more. Good. Let's come back around to AP. And we're looking to be close to the center on the AP. We're looking to be close to the spinous process in the AP. We're a little bit ipsilateral, so I'm going to adjust it. Let's go back lateral. Let's use this as a method to adjust the position. So one of the things that I like about the bevel needle is the ability to adjust its trajectory. And we will come back to the posterior portion of the vertebral body, right here. You don't want to go too far, right? And I'm just going to lay it over with the directional capability. You put the appropriate amount of torque on it. Remember, this is an 11 gauge needle. This is something you'll be able to correct dramatically. All right, so very near the center portion there. Let's take a look lateral, AP rather. And you can tell just by the orientation of the needle that we're going to be definitely farther midline by far than we were last time. And we have nailed the center portion of the vertebral body. So this is a good way because it doesn't go through the centimeter to a little over a centimeter tube of bone that is the pedicle. You access it just anterior to the pedicle at or above the equator of the pedicle, the midline. And you can really rock or arm this over, and you don't have to worry about breaking the pedicle because there is no pedicle that transverses. So you can really modify the final position within the vertebral body, and it's tailor-made for adjusting the trajectory. So right now, our chicken has been cooked. So let's focus back over to the vertebral body. This is the area of ablation zone, nice elliptical area of ablation right in the center portion of the vertebral body. And these are all size. These are size 10 millimeters. It goes all the way up to 20. You can size for an ablation zone that's at the whole of the vertebral body. You just size up. But this is a good example of the osseous ablation. Let's do one more approach. We'll do what's called the modified inferior plate extraorbicular approach. So let's go 45 degrees toward you. One of the things that we like to differentiate about the approaches, one is a transpedicular, one is a parapedicular, and one is an extrapedicular. So para alongside of the pedicle. I'll go down to this. One is outside of the pedicle, or extrapedicular. So on this view, just anterior to the pedicle, below midline, is our target, and we go 45 degrees. As this was originally developed, it was avoiding all solid organs at 45 degrees with no chance of injury. So this is our approach, will be just above the end plate, hence the name modified inferior end plate extraparticular approach. And at 45 degrees, we're 45 degrees not only to the patient, but the room. So our angle is about 45 degrees. So we'll go in and approach it at 45 degrees, just above the inferior end plate. And so we're just anterior to the pedicle, just above the inferior end plate, and that's a good access point right there. So at this point, I'd like to take a view AP. And so the purpose of this is to make sure we can have access even when you can't see the pedicle. When the vertebral body is vertebral planar, typically it compresses from top to bottom, and you will always be able to get in this. So here is the approach on the AP. It's a very different approach, isn't it? So this is just above the end plate, and there's no neurovascular bundle. You can stick your thumb in the vertebral body using this approach, and there's really nothing there. The segmental artery would be present about the midline, and everything below that, just anterior to the pedicle, is a wide swath of territory that's relatively avascular and aneural. And this is good for when you can't see the pedicle, to get out around the pedicle when you need to do things like tumor ablations, to stick big things in the vertebral body, because this is such a wide safe zone, and also in very compressed levels. And so I will go ahead and place this in farther. And once we hit about the midline, arc a little bit toward me to make that more AP. Yep, once we hit midline, let's go lateral. We should be in the middle to anterior portion of the vertebral body.
Approach.
And at this point in time, whatever appliance you're using, so that's nice positioning. So middle to anterior portion on the lateral view, smack in the midline on the AP view, and whatever appliance you're putting in there, device, implant, you can go ahead and deploy that at this point in time. If it's a balloon, you can use a balloon. What we may do is I may go ahead and use Kyphon Assist if I have to re-access that. This is one of the ones I wanted to show you. Do we have a wire? Yeah, perfect. Okay. Do you have a K-wire?
K-wire.
That's okay. I'll re-access this. So one of the things, the directional capability I'd like to show you is the Kyphon Assist. Oh, that's okay. I'll just re-access it, no worries. So let's come back around to AP if we would. So the Kyphon Assist is a scooped cannula that allows for directional capability. We're demonstrating the Osteocool, also from Medtronic Kyphon. And this is the Kyphon Assist from Medtronic Kyphon. Arc a tad bit toward me, if you would. So good midline. Let's go back lateral. And the scoop on the cannula is a cutout portion of cannula that allows directional capability of the balloon. Okay, so that's a nice position. I'm going to put it just a little bit contralateral and a little bit anterior to where we are right now. Okay. just go with a balloon. You can drill from this point on, but I just am going to place the balloon, as it looks like we're doing fine on our position. So, balloon placed, fantastic. So we'll use the drill to clean out some portions that are left there. There we go. So I want to get a final position of our distal tip. So when we have a lateral, let's take an AP, and then we'll go back to lateral for the balloon inflation. So this will give you an idea about where we are in the vertebral body. So we've covered the transpedicular, the parapedicular, the modified inferior inflate extrapedicular approach. And we're now, it's okay. We're now using a Kyphon assist balloon that's present, by the looks of it, toward the middle of the vertebral body in a very, very nice position. I'm going to move it just a little bit more contralateral. And put that sucker right there in the middle. All right, I like that. So let's go back lateral. So all three approaches we've demonstrated to the osteocool that is for tumor ablation and tumor fractures. And that is a nice position that we're satisfied with. Center anterior portion, and this is for a unilateral approach, of course. All right. See the marker band just distal to that cannula. We can also see the cannula is pointing superiorly, and I have a white marker on my cannula that dictates which direction the balloon is going. So we'll give a little inflation with contrast. We see it come up. And that's a very nice directional inflation. So the reason it's going directly up is because the scoop on the back of that cannula is directing the balloon that way. And let's take an AP shot of that. And we have cement mixed, fantastic. And we'll show you the balloon position, and then we will inject some cement. Good. A little bit ipsilateral, but not too bad, keeping in mind that this will be mostly a bilateral technique. Also, the discogenic sclerosis over there will definitely direct your balloon away from it. That sclerosis in the vertebral body. They're at the 2-3 level on the patient's left.
You'll have to hold that one.
No worries. So this is the CDS, the cement delivery system. This is the gun with the actuator as the trigger, and the release is the button back here that causes automatic release. This is put in, this is hydraulic, and this is X-speed cement.
Correct.
Right. Kyphonic speed. So we'll take a look at AP, see where we are with the cement delivery. And you just actuate it, trigger it. Cement's going in, very nice. And at this point, we'll go ahead and shift to the lateral. And as predicted, it's going right into the cavity created by the balloon. And progressive filling of the cement. X-speed has a working time of about 8 minutes. It is high viscosity cement on the range of about 250 to 350 Pascal seconds, depending on when you measure it. Of course, the viscosity increases as it polymerizes, and it polymerizes more at temperature than it does in a cadaver, and it hardens faster in the body, more so than it does on the back table. Yeah, it's all the cement. So, nice distribution. So let's put in more. Just like everything else in life, more is always better in almost every single regard. Right, gentlemen? More is better, remember. Except for maybe taxes, that's not better. So put in a little bit more speed. We can see the cement delivery coming down, and this is a pretty good amount. And we see decent filling. So let's take an AP shot and see how we're doing. Very nice. It's interesting how it fills in and around that area of sclerosis. Go ahead and let's go back lateral. Remember I told you it's areas of sclerosis, discogenic sclerosis like that will be very dense, usually modic type 3 changes, and they will rarely fill with cement. So that's exactly the pattern that we would have predicted just from looking at this. So put in a little bit more. Not a lot, just a little bit more. Fill it from end plate to end plate, primarily between the pedicles. That's our goal. So whenever you have a goal about fixing a fracture, we're going to try to maximize the amount of reduction. We want to fill the vertebral body with a permanent supportive cement, and we want to do it from end plate to end plate. And we want to get a lot of the support directly between the pedicles. And this is about the amount that we need. Looks to be 14 cc's. How about that? So for those of you who are not using sufficient cement, one of the most common errors, let's come back AP, is not using enough cement. And it's based on the Swiss registry data. The amount of cement that you use was the single modifiable thing that you could do to increase the pain relief for the longest amount of time. And so this is 14 cc's. I'd have to say that this is not an unusual amount that I would use for a vertebral body. You can't overfill, but overfilling is really done to increase the stiffness beyond the native stiffness. It's very difficult to do in a live person. This is only really has been demonstrated in a cadaver, and see, it effectively fills almost every portion of the vertebral body with the exception of that discogenic sclerosis. Very nice. Okay, so before we pull the needle out, we will want to put the stylet back in to ensure there's no tail. And we can leave that a little bit until it hardens before we pull it out. Additional demonstration. Yeah, I can show them what the osteocool looks like in the bone. I do. Use the bevel. And can we raise it up just a little bit? Give some working room. Let's just go up here where we were. A typical transparticular approach. All right. And before we transgress, let's check, make sure we're in the posterior portion of the vertebral body, and then we'll put this probe all the way out to the front. I think we only have 10 millimeter probes, but that's 20, we have a 20. Okay, so we'll use a 20 in this case. Give us a little bit better ablation zone. Okay, let's go ahead and come back around AP. And I usually like to tap the cement down to make sure it gives a nice click before we remove the interstylet. So that's good position right there. That's the place we'll put the Osteocool probe. I didn't use a drill. I just went ahead and went out, skipped a step. I'll remove the other needle, and then we'll...
So just back that up.
Sure, yeah.
And then you can use that drill to tell you which size probe to use.
Yeah. So let's determine, I'll get this back to the normal position of the cannula. And at this point in time, let's go back lateral, and we'll use the color coding on the proximal portion of the drill to figure out what size is best size, since we do have different sizes of cannula. So I'll back the cannula up. Put the drill in the position of the probe, and we're between blue and orange. So I will pull the drill out so you can see the position of the cannula right there.
Put that white satellite in real quick.
Yep.
And that'll show you your posterior.
All right. So, yeah, I can back it up more. Why don't we just we use a 20. All right, and this is a typical Osteocool probe, has markers on it, fits through the cannula, same thing we use to cook our chicken. And this will connect to the posterior portion of the cannula. So here it is, nicely done. I'll back that up just a little bit. And a combination of two probes in here will produce the elliptical burn that we saw with the chicken. This is an example of an Osteocool. I think that is about it. So, let's do, yeah, the Curette. Thank you. So, this Curette goes at a 45 and a 90-degree angle. And it's, you can actuate it by the trigger, and you can lock it using this. It can lock at 45, and it can lock at 90. So this is done for taking care of sclerotic bone and creating a pathway for cement or balloon or whatever you want to. So I'm going to angle it superior, and I'm going to deploy it. And you can see, I'll go live here. You can see this rotate, right? Rotate around, you can hear the bones score, and this can create room for cement, or it can create room for a balloon. And it's very nice. You can put it at a 45-degree angle, or you can put it at a 90-degree angle and have it locked based on the trigger on the posterior portion of the instrument. And that looks like it. I'd like to thank everybody for your attention. I guess we can open it up to questions or comments. Thank you.
Well, excellent. Thank you very much, Doug. That was an excellent presentation on multiple different approaches on how to access the vertebral body. Let's see, let's go back to the questions that people had online. Okay, the question of rare procedural complications, fracture or cement leak. So do you think this procedure should ideally be done by spine surgeons as opposed to pain specialists?
No, not at all. So if you look at what's been done and look at the complications, so probably the best demonstration of the number of complications has to do with the U.S. registry. So it's been over 1,000 cases. There's only 2 adverse events, primarily related to sedation, and there are absolutely no neurologic injuries in over 1,000 patients. So this does not have to be done by a spine surgeon. If you do, you will limit access, and the mortality related to this, to each spine fracture, is between 8 and 9 times age-matched controls. So the last thing we want to do is limit access to this. We want to make sure and have as much access to it as we possibly can. So this should be done by all specialists. Interventional pain, there's about 5 or 6 specialists that do that. Orthopedic surgeons, neurosurgeons, interventional radiologists, all comers.
Excellent. For patients with a lot of hardware, where they fracture with hardware in place, is there particular approaches you like to use for those types of cases with a lot of hardware in the pedicle? So
one of the approaches I really like, and one of the main reasons why we developed a modified inferior plate extrapedicular approach, is to get around hardware. You can have 5.5, 6.5 screws, and people say, well, I just use a parapedicular approach to get around the screw. And absolutely, sure, that works sometimes. When it doesn't work, you're stuck if you don't know another approach. So even if you have large screws, let's say you have offset pedicle screw and rod construct where the rods are offset, very difficult to get around, and there are scenarios that are difficult to get around. The extrapedicular approach, where you don't even have to come around in and around the pedicle, is ideal for that.
Excellent. Thank you very much. Well, I think they're getting close to getting prepared for the Vertiflex procedure, and we'll get you back in a little bit here, Dr. Beall, and get you back for the demonstrations with vertebral augmentation.
Thank you, guys.